Hi, my name is Dr. Gizelle Popradi. I'm a hematologist at the McGill University Hospital Center. Today, I'll be talking about chronic graft-versus-host disease as part of an educational webinar series for Cellular Therapy and Transplant Canada. These are my disclosures. These are some general references for today's talk. They include the ASH SAP 7th edition, the chapter on stem cell transplantation, a similar chapter in the EBMT handbook, and the online module MPN eSimple on chronic graft-versus-host disease. Other references will be embedded in the slides. The objectives of today's talk are to differentiate chronic from acute graft-versus-host disease, understand the impact of chronic graft-versus-host disease on mortality and allogeneic transplant survivorship, appreciate the pathophysiology of chronic graft-versus-host disease, identify its risk factors, be able to diagnose it using current NIH consensus criteria, and become familiar with prevention strategies and evidence-based therapies. Graft-versus-host disease is a complication following an allogeneic tissue transplant. It is an immune reaction whose result is a multi-system clinical syndrome. It is a direct result of one of the immune system's most important roles, which is distinguishing self from non-self. When the host attacks the graft in the setting of transplant, rejection can occur, but today we're talking about the flip side, the graft attacking the host, in which graft-versus-host disease can occur. There are three types of graft-versus-host disease. We'll be talking about that arises following an allogeneic stem cell transplant, but it's important to be aware that it can exist following solid organ transplant and following a blood transfusion. These types of graft-versus-host disease usually have acute features. In order for graft-versus-host disease to occur, Billingham's three criteria, which were first described in 1966, must be met. The graft must contain immunologically competent donor cells, the host must be unable to reject or eliminate the donor cells in the graft, and the host and the graft must be antigenically different from each other. The first proof of graft-versus-host disease came from mouse experiments in the 1950s. In these experiments, irradiated mice were given spleen and marrow suspension injections from healthy mice. The investigators noted that hematopoiesis was restored in the irradiated mice, but they developed clinical features of graft-versus-host disease, primarily scruffy fur, runting syndromes, followed by death. Thus, in the allogeneic transplant setting, graft-versus-host disease is an immune reaction. In patients with GvHD, donor-derived immune cells will view the recipient's body as foreign and attack normal tissue. It is characterized by high levels of pro-inflammatory cytokines, which can enhance activation and proliferation of effector T cells. At the cellular level, donor-derived effector T cells will attack immune-suppressed recipient patient tissues, responding to genetically determined proteins on recipient cells. And these are proteins that are class 1 and class 2 human leukocyte antigens. Graft-versus-host disease, both acute and chronic, is a major cause of mortality. Among the nearly 44,000 patients with leukemia who underwent allogeneic transplant and died during an observation period of 1980 to 2015, graft-versus-host disease was the main cause of death in 19% of patients. It followed behind infections and relapse. It's important to understand that acute and chronic graft-versus-host disease are distinct conditions without time restriction. But when we talk about chronic graft-versus-host disease, most of the time we're talking about the classic chronic form, which occurs after day 100 following transplant. There is clearly a well-defined chronic overlap form in which patients may have features of both acute and chronic graft-versus-host disease. But as a rule, both acute and chronic graft-versus-host disease can present at any time point after transplant. These are some fun facts about chronic graft-versus-host disease. Its incidence is approximately 50%, but the range is quite wide, 40 to 80%, depending on which reference you consult. It's clear that the incidence has increased during the last 2 decades. This is probably due to many factors, but primarily 3. First, the increasing patient age at time of transplant or recipient age, the increasing use of unrelated and or mismatched donors, in particular the use of haploidentical transplants, the increased use of peripheral blood stem cell grafts. The onset of chronic graft-versus-host disease is typically 4 to 6 months after transplant, and 3 or more organs are involved at the time of diagnosis in the majority of cases. Chronic graft-versus-host disease is a major cause of late non-relapse mortality. In one study, it was associated with a 35% transplant-related mortality, which was only 11% in patients who did not have chronic graft-versus-host disease. If we look at its long-term survival, long-term impact rather, one will see that in 5-year relapse-free survivors of allogeneic stem cell transplant, chronic GvHD is still a major cause of death. In this study of over 2,000 transplanted patients who were alive and well 5 years after the transplant, it was the 4th leading cause of death, following relapse, infection, and secondary malignancies. Chronic graft-versus-host disease is also associated with a high morbidity or high disease burden. Many studies describe a poor quality of life in patients with graft-versus-host disease and note that it is worse in those with more severe chronic graft-versus-host disease. About 1/3 of patients with chronic GvHD will suffer clinical depression and significant anxiety. Patients who report active, moderate, or severe NIH chronic graft-versus-host disease will report worse quality of life, lower performance status, higher symptom burdens, and are more likely to be taking prescription medication for pain, anxiety, and depression compared to those with resolved graft-versus-host disease. It's clear that disease severity and organ involvement predict health-related quality of life and patient function. Patients with chronic GvHD may require long-term immunosuppressive treatments and are often readmitted to hospital for complications such as infections. Thus, the disease is associated with a high economic burden. Over the decades, numerous risk factors for chronic GvHD have been established. I would say the most important ones are listed on the slide and include higher degree of HLA mismatching between donor and recipient, older age of the donor, a history and the severity of prior acute graft-versus-host disease, the source of the stem cells, with peripheral blood stem cell grafts being associated with higher rates of chronic graft-versus-host disease compared to marrow or cord blood grafts. Also important are donor and recipient gender disparity, in particular female donor to male recipient transplants, alloimmunization of the donor, administration of donor lymphocyte infusions post-transplant, and the use of total body irradiation in the conditioning regimen. The pathophysiology of chronic graft-versus-host disease is quite complex, and it is different than that of acute graft-versus-host disease. It is also beyond the scope of this talk to give you a detailed overview, but I can refer you to the references at the bottom of the slide. Chronic graft-versus-host disease is mainly characterized by impaired immune tolerance mechanisms affecting innate and adaptive immunity. Both autoreactive and alloreactive donor-derived T and B cells play a role, and we note that the end product of the chronic graft-versus-host disease reaction is chronic inflammation with subsequent scar formation and fibrosis. If we were able to successfully prevent chronic graft-versus-host disease, we wouldn't have to talk about this disease, but we are not able to do so. However, we do have some strategies that will lower the rates of chronic GvHD after transplant. The first, and the most important, is the pharmacological prevention of acute graft-versus-host disease. In Canada, this is usually accomplished for myeloablative transplants using a GvH prophylaxis regimen of tacromethotrexate or cyclosporin methotrexate. In the reduced intensity setting, the GvHD prophylactic regimen is often tacrolimus or cyclosporin combined with mycophenolate mofetil, known as MMF. Another important prevention strategy is the use of T-cell depletion. This can be done in vivo with ATG or post-transplant using post-transplant cyclophosphamide. It can also be done ex vivo by depletion of T cells expressing alpha-beta receptors. Since B cells are involved in the pathophysiology of chronic graft-versus-host disease, intuitively it makes sense to devise preventive strategies that prevent the development of pathogenic B cells, but at present there's only preclinical data. It also makes sense to, when at all possible, select well-matched donors, so avoid HLA mismatches and avoid gender mismatches, in particular female donors to male recipients. Before I move on, I want to say a few words about ATG, a very important preventive strategy that causes in vivo T-cell depletion. At least 4 important randomized clinical trials have been published between 2009 and 2017, including the Canadian trial led by Dr. Irwin Walker, in which many Canadian transplant centers participated. Although the product used, the primary endpoint, the conditioning, the donor, and sometimes GvH prophylaxis varied from trial to trial, the results are fairly clear. The use of ATG in vivo T-cell depletion decreased rates of chronic graft versus host disease, and this strategy is highly encouraged in both unrelated donor and related donor transplants. Chronic graft versus host disease has many faces clinically. And unfortunately, a variety of different manifestations can make the diagnosis difficult. It can present as one discrete lichenoid lesion in one organ like the mouth, or have a multi-system presentation that resembles an aggressive autoimmune disease. Regardless of what it presents with, it's important to recognize it early in its course so that treatment can be instituted promptly, because it is associated with significant morbidity and mortality, as we established. But at the organ level, it can cause important joint contractures that limit range of motion. It can result in loss of sight and be associated with end-stage lung disease requiring oxygen or possible lung transplant. Mortality from this disease is usually due to chronic immune suppression that leads to recurrent or life-threatening infections. Making the diagnosis of chronic graft versus host disease accurately is very important. To guide us with making diagnosis and the severity scoring, we refer to the NIH Consensus Development Project on Criteria for Clinical Trials in Chronic GvHD, in particular the 2014 Diagnosis and Staging Working Group Report, which is a revised version of the 2005 document. The document states that if certain diagnostic signs are present, one has sufficient evidence to make a diagnosis without doing other tests. They also point to a category of distinctive signs, which are not ordinarily seen in acute graft versus host disease, are very suggestive of chronic GvH, but if present, are insufficient alone to establish an unequivocal diagnosis of chronic graft versus host disease. In that case, biopsy, laboratory, and imaging findings are recommended. This is a table representing the diagnostic distinctive and another category of common signs and symptoms seen in both acute and chronic graft versus host disease. Most of the diagnostic findings will occur in mucosal areas or the skin, but can also occur in the lung, where exceptionally one needs lung biopsy to prove bronchiolitis obliterans syndrome, and occur in the muscles and joints where it may manifest as fasciitis or joint contractures. This slide shows some pictures of diagnostic findings of chronic graft versus host disease. One of the most important diagnostic findings is lichen planus, which can occur on the skin, in the oral mucosa, or in genitalia. It's characterized by skin eruption or oral eruption associated with purple papules that are itchy on the skin, not in the mouth. They may show white lacy network on their surface. The oral changes are similar to skin changes, but may be associated with a lot of oral erythema and ulcers and mucoceles. Other diagnostic findings on the bottom left include poikiloderma, associated with pigmentation changes, atrophy, and telangiectasia of the skin. And lastly, one can see morphea or localized sclerosis changes of the skin, in which the skin appears to be thin and shiny, usually very pinchable, and sometimes associated with signs of acute inflammation. If we look at the organs involved by chronic graft versus host disease in bone marrow and peripheral blood recipients, we can see that the majority of patients will have skin involvement and mouth involvement, followed by involvement of the eyes, liver, and gut. But also serosal surfaces, the lung, nails, genitalia, esophagus, muscles, and joint may be involved. Scoring of graft versus host disease severity is performed according to the NIH consensus document. Patients are classified as having mild, moderate, or severe disease based on the number of organs involved and the degree of involvement. This is very important because it will suggest to you when to initiate treatment. We also know that disease severity and organ involvement predict health-related quality of life and functionality. And lastly, several studies have shown that the NIH Global Severity Score can predict overall survival and non-relapse mortality. Thus, the scoring system has prognostic value. This is an example of one portion of the NIH scoring document. showing you the scoring of joint and fascial disease and genitalia, as well as other indicators that may be present in graft versus host disease. I invite you to consult the full document. Let's turn now to talk about the treatment of chronic graft versus host disease. Timing of disease is very important. So it's important to start therapy as soon as the diagnosis is made, as long as therapy is appropriate. And is almost always appropriate in patients who have 3 or more organs involved, or when a score of greater than or equal to 2 is present in any single organ, because that indicates moderate to severe NIH chronic graft versus host disease. These patients generally require systemic immune suppressions. Symptomatic mild NIH chronic graft versus host disease can often be managed locally. For example, the use of topical steroids for skin involvement. It's important to remember that chronic graft versus host disease takes time to respond, so most responses should not be done until at least 8 weeks have elapsed, or 3 to 6 months in the presence of deep cutaneous sclerosis. However, this is not to say that patients should not be observed frequently for signs or symptoms of disease progression, which may prompt you to change therapy. Long-term therapy with immune suppression is generally required. Most patients are on treatment for at least 6 months. And when dose reduction is performed, it should be done in a stepwise manner. This is a potential therapeutic algorithm for chronic graft versus host disease. First-line therapy usually involves continuing or restarting the original immunosuppressive agent, such as a calcineurin inhibitor, and combining it with systemic corticosteroids, 0.5 to 1 milligram per kilo per day, with topical therapy as indicated. If patients are responding, then that is great news. And it's suggested that one tapers steroids and immune suppressants slowly as clinically feasible. But if patients are not responding after 8 to 12 weeks, or if they are clearly progressing on first-line therapy, it's important to consider that the patient might have steroid refractory resistant disease, and then focus on second-line therapy or clinical trials. I'll say a few words about frontline therapy. Despite decades of research, we are still stuck with steroids alone in the front line. Many trials have been published looking at this question, and 2 of the most important studies, I think, are included on the slide. These are trials by Paul Martin and colleagues published in 2002 and 2009. The first study from 2002 looked at combining cyclosporin plus prednisone to prednisone alone for chronic graft versus host disease. This was a randomized trial. Unfortunately, the authors noted that the administration of cyclosporin did not reduce transplant-related mortality in GvH patients, but they did note that treatment with cyclosporin and prednisone could reduce the risk of steroid-related toxicity. So the combination may be valuable up front. The second study, published in 2009, was, I think, quite disappointing for members of the transplant community. Paul Martin and colleagues evaluated MMF for the initial treatment of chronic graft versus host disease. Unfortunately, this trial closed early due to an estimated low probability of achieving the primary endpoint, which was resolution of chronic GvHD and withdrawal of all systemic treatment within 2 years without secondary treatment. They also noted that the hazard ratio of death was higher for those in the MMF arm. So overall, a disappointing study. And we are still stuck with steroid monotherapy as frontline therapy. When assessing patients with chronic graft versus host disease to determine if they are responding, it's important to know what the standardized response definitions are. These are listed on this slide and come from a publication by Stephanie Lee and colleagues. The ideal outcome is, of course, complete response, which means complete resolution of all signs and symptoms in all evaluable organs without need for additional therapies. Partial response is also valuable and defined as an improvement of at least 1 point on a 3 to 7 point scale in at least one organ without progression in other organs or sites. Undesirable outcomes are unchanged, mixed response, or progressive disease under the lack of response category, and these will prompt a change in therapy. Unfortunately, about 1/3 of patients will develop steroid refractory or resistant disease. Again, it's important to know, it's important to be able to identify these patients as soon as possible so that therapy can be changed appropriately. Fortunately, a standardized definition exists to guide us, and this comes from a 2018 publication, a joint EBMT, CIBMTR, and NIH task force publication. Steroid refractory resistant disease is defined as progression while on prednisone, at least 1 milligram per kilo per day for 1 to 2 weeks, or stable disease while on at least 0.5 milligram per kilo per day for 1 to 2 months. There also exist definitions of steroid dependence and intolerance, which could also prompt change in therapy. Traditionally, steroid refractory chronic graft-versus-host disease has been associated with bad outcomes. In the seminal study by Akbeck and colleagues published 20 years ago in Blood, about 60% of patients had failed primary therapy, and the authors determined that the probability of GvHD-specific survival at 10 years was lower in these failed patients compared to those who did not fail, 38% versus 51%. They also noted that patients who became refractory to all immunosuppressive therapy had a very short life expectancy, with 20 of 26 of them dying within a median of 1 month from becoming refractory to all therapies. This study was also important in establishing certain risk factors when present at the time of diagnosis of refractory disease that could predict for better or worse survival. So they determined that 5-year disease-specific survival for refractory chronic graft-versus-host disease could range anywhere from 4% to 91%, depending on whether or not certain risk factors were present. Risk factors included extensive skin involvement, low platelets, Kronofsky performance score less than 50, and progressive type onset disease. Fortunately, we have some more contemporary data from this large study by Soisier and colleagues looking at over 1,200 transplanted patients that suggests that the incidence of steroid refractory graft-versus-host disease can be low in some patients, and that the 3-year overall survival for steroid refractory patients is better than what we determined it to be 2 decades ago. The authors determined that the 3-year cumulative incidence of steroid refractory chronic GvHD ranged from 14.5% to 35%. It was highest in those who had a history of steroid refractory acute disease and lowest in those who had no history of prior acute GvHD. The 3-year overall survival for steroid refractory patients was 63%, which is better than I've shown you in the Akbeck study, but still worse than those patients who were responders to steroids and whose 3-year overall survival was 72.5%. Over the decades, many different clinical trials have been published looking at agents to treat steroid refractory or resistant disease, and some of these agents are listed on the slide. Unfortunately, many of these studies were small, retrospective, and uncontrolled. None of these agents became FDA approved specifically for chronic graft-versus-host disease. However, in the last few years, 3 novel oral therapies have been FDA approved specifically for steroid refractory graft-versus-host disease, chronic that is, and more data has accumulated on the utility of ECP for this disorder alone or in combination with other therapies. So this slide provides you with a nice overview of what I think are what I believe are the 4 most important therapies for steroid refractory chronic graft-versus-host disease: ECP, Ibrutinib, Ruxolitinib, and Volumatinib. In the middle column, one has the strength of supporting evidence, and on the far right, the key reported outcomes, which are generally overall response rates. Let's talk about these agents one by one, beginning with ECP. ECP is not FDA approved specifically for GvHD, but it has a long history of being used successfully in the treatment of both acute and chronic graft-versus-host disease. Not too long ago, a meta-analysis of nearly 20 studies was published, pooling the data for chronic GvHD steroid refractory responses on ECP. One can see that the response rates are quite promising. They range from 48% in the lung to 74% in the skin. ECP also has the advantage of being a non-immunosuppressive therapy. There exist at least 3 expert groups who recommend ECP for graft-versus-host disease: the American Society for Apheresis, the UK Photopheresis Society, and the British Society for Blood and Marrow Transplantation. All of them indicate it for steroid refractory or dependent chronic graft-versus-host disease in at least the second-line setting. The recommended schedule is 1 cycle, so 2 treatments back-to-back, every 1 to 2 weeks for at least 8 weeks. Now I'll turn to talk about drug therapy for steroid refractory chronic graft-versus-host disease. Ibrutinib is the first drug that was approved by the FDA specifically for chronic graft-versus-host disease. It had already established itself as an effective drug in the treatment of B-cell indolent lymphomas, thus giving us an idea about how it could have an impact on the B-cell pathway. And in fact, in graft versus host disease, it may be involved in downregulating B-cell survival, but it seems to have another action. It can inhibit IL-2 inducible T-cell kinase, which may inhibit activation of T-cell subsets driving immune reactivity against healthy tissues. Ibrutinib was approved on the basis of a very small phase 1b, phase 2 study in which patients who received less than or equal to 3 prior treatments for chronic graft versus host disease could be enrolled. 42 patients were enrolled. They received Ibrutinib at a dose of 420 milligrams daily until progression or unacceptable toxicity. The primary endpoint on the top right was chronic GvHD response per NIH 2005 response criteria. This was a positive study. The overall response rate was excellent at 67%. 1/3 of responders had a complete response, and nearly 80% responded at the time of the first response assessment, which is about 1 month into therapy. Also, durable responses were noted. Responses were seen across multiple organs, so responses were recorded in the skin, mouth, gut, and liver. And patients who had multiple organs involved had multiple organs respond to the therapy. Ibrutinib was also associated with improvement in chronic graft versus host disease symptoms and severity as assessed by patients and clinicians. It was shown to be steroid sparing, and adverse events were in line with those expected in patients with chronic graft versus host disease. The top 3 treatment emergent AEs were fatigue, muscle spasm, and diarrhea. It's important to remember when using Ibrutinib that drug-drug interactions can occur because Ibrutinib is primarily metabolized by the CYP3A enzyme system. Another drug that was recently approved by the FDA for steroid refractory chronic graft versus host disease is Jakafi, which is a JAK pathway inhibitor. It appears that JAK signaling plays a role in graft versus host disease pathophysiology. Again, the way it plays a role may be quite complicated, but it seems that JAK signaling is important in the induction of pro-inflammatory cytokines, and that blockade can decrease cytokine production and perhaps favor regulatory T-cell differentiation. JAK inhibition may also modulate dendritic cell differentiation and maturation and lead to less effector T-cell activation. Again, I invite you to read the references below for a more detailed description of pathophysiology. Ruxolitinib was approved for the treatment of steroid refractory dependent chronic graft versus host disease on the basis of the REACH-3 study, a large randomized phase 3 clinical trial. Patients over the age of 12 who had steroid refractory dependent graft versus host disease, either NIH moderate to severe, defined as listed in this slide, were randomized 1-to-1 to receive either ruxolitinib 10 milligrams twice a day with steroids with or without a calcineurin inhibitor, or to investigators' choice of best available therapy with steroids with or without a calcineurin inhibitor. The primary time point for assessment was week 24, and after that point, patients not responding to best available therapy were able to cross over to ruxolitinib. The primary endpoint of the study was overall response rate at week 24 using NIH consensus criteria. An important note about best available therapy. So investigators in the study were able to select their preferred agent. The majority of investigators used ECP, followed by MMF, Ibrutinib, and a smattering of other medications as listed on the slide. This was, of course, a very positive study. Ruxolitinib met the 24-week primary endpoint, demonstrating a higher overall response rate of nearly 50% compared to best available therapy, where the response rate was only 25%. Complete responses were not common in either group, but partial responses were nearly double in the ruxolitinib arm compared to best available therapy, and there was a lower rate of chronic GvHD progression in the ruxo-treated patients at 2.4% compared to 13%. The drug was also associated with better failure-free survival at week 24. The median duration of failure-free survival was not reached in the ruxo-treated patients, but was only 6 months in the patients treated with best available therapy. The drug was also associated with subjective responses using the modified Lee symptom scale, and a higher best overall response rate in patients who attained a CR or PR at any time compared to best available therapy. This best overall response lasted longer in patients who received Ruxo compared to best available therapy. The safety profile of the drug was consistent with previous observations and, again, with what is expected in patients with chronic graft-versus-host disease. The most frequent AEs in the ruxolitinib arm were anemia and thrombocytopenia. The last drug that has been approved recently by the FDA is Volumatinib, and this drug was approved on the basis of the Rockstar study, examining its use for chronic GvHD after 2 or more prior lines of therapy. This was a multi-center phase 2 randomized study, randomizing patients to receive either 200 milligrams or 250 milligrams twice daily. The drug in question is an oral selective inhibitor of Rho-associated coil-containing protein kinase 2. Fortunately, we can abbreviate this as ROCK2. Thought to reduce type 17 and follicular helper T cells through downregulation of STAT3, and thought to enhance regulatory T cell function. 66 patients were randomized to each dosing schedule. They were heavily treated. They had 2 to 5 prior lines of therapy, a median of 3, and importantly, this study included patients who'd failed Ibrutinib and ruxolitinib. The primary endpoint was overall response rate. With a median follow-up of 14 months, the best overall response rate reached by the 200 milligram twice a day group was 77%. All affected organs demonstrated complete responses. Median duration of response was just over a year, and just under half of patients remained on therapy for more than a year. Importantly, symptom reduction was noted in patients who received both dosing schedules. Also, few drug interactions were noted, and again, AEs were consistent with those expected in patients with chronic GvHD receiving corticosteroids and other immune suppressants. So how can we summarize the state of chronic graft-versus-host disease therapy? I would say that in the front line, steroids are still the cornerstone of therapy, with or without a calcineurin inhibitor, and local therapy is appropriate. In the second line and beyond, we have access to 3 novel agents, and if we believe the data from the REACH-3 randomized controlled trial, ruxolitinib is superior to Ibrutinib and ECP. Ruxolitinib and Ibrutinib have been approved by the FDA after failure of at least 1 line of therapy, and Volumatinib, which has been approved after failure of at least 2 lines of therapy, could be an excellent option one day for patients who have failed Ibrutinib and ruxolitinib. I think that ECP is an excellent option for patients with steroid refractory chronic graft-versus-host disease if it's available in their center. It is not an immunosuppressive treatment, and it may be useful in combination with some of the oral agents I've mentioned above. This is personal opinion and not based on widely published data. And lastly, I must say that when considering therapy for chronic graft-versus-host disease, at all times, clinical trial enrollment should be prioritized. This is my final slide, and it contains my take-home points. Firstly, chronic graft-versus-host disease is clinically heterogeneous and distinct from acute graft-versus-host disease. It's a major cause of late transplant morbidity and mortality. Its major risk factors include HLA disparity between donor and recipient and prior acute graft-versus-host disease. Rates of chronic GvH may be lowered using ATG as a prophylactic strategy. Its diagnosis and severity grading are accomplished using the NIH consensus criteria. And lastly, frontline therapy is steroid-based, but up to a third of patients become steroid-resistant or refractory and need second-line therapies. These may include ruxolitinib, Ibrutinib, Volumatinib, ECP, and others. I thank you very much for your attention.